Sir's mic is on now.
Yes, yes.
Yes, sir. We are live now.
Good evening to everyone. I'm Dr. Omkar Swami on behalf of Emcure Pharmaceuticals Limited. Welcome you all in this 22nd session of No Thrombosis, wherein we discuss live inbox cases. I would like to share very good news to our course director and our moderator. So we have received an award of most engaging scientific platform in India for this particular No Thrombosis event, and we always feel this is all keen interest of Dr. Hiremat sir, Dr. Jabir sir, and Dr. A. Srinivas Kumar sir. So this was across the country with different scientific engagements which has happened in last 1 year. So we have also participated in this and sharing all these details about thrombosis, and we received first award. Thank you very much. So today we are meeting with three interesting...
No, Dr. Omkar, wait a minute. Let me congratulate you for this award, because I think we've been here, we've been trying to give our inputs, we've been trying to contribute, but I think the amount of inputs you have given, the amount of trouble you have taken, is really phenomenal. I mean, we grew from something like 200, 300 in the beginning, and by the time we reached the fourth or fifth webinar, we're already 1,000 and beyond. So that really speaks a lot about your contribution to the meeting, getting correct people, getting correct scientific agenda, and creating a forum which would interest everybody. And that's why so many have joined in today, as well as the last many presentations.
Thank you. Thank you. It's all we feel that your keen interest and all our moderators' keen interest make this program successful. So I will just briefly introduce all the faculty today because of paucity of time. So it's my great pride, privilege, and honor to welcome and introduce our course director, Dr. M.S. Hiremat sir. Sir has been consistently participating in this program for last two events and giving his pearls of wisdom in each and every. Thank you very much, sir, being a part of this program. I also welcome and thanks Dr. Jabir Abdi sir, sir, Senior Consultant and Director of Clinical Research at Lisi Hospital, Cochin. Sir has also been present with us for last 22 sessions. Thank you very much, sir, being with us for last sessions consistently. I also welcome our next moderator, Dr. A. Srinivas Kumar sir from Hyderabad. Welcome, sir. Thank you very much, sir, be part of this program consistently. Today we will be having three cases. Dr. Niranjan K would be presenting on anomalous RC angioplasty with diagnostic catheter. He's a head of the department and senior consultant interventional cardiologist at R.L. Jalappa Narayan Udalaya Heart Center, Kolar, Karnataka. I welcome Dr. Niranjan. I also welcome Dr. Salil Vaidya sir, consultant cardiologist at Ruby Hall Clinic, Pune. He will be presenting challenging case of left main bifurcation. We have our third case today as a challenge in Corona times by Dr. Navajit Talukdar sir. He is a senior consultant interventional cardiologist and electrophysiologist at Batra Hospital and Medical Research Center, Delhi. So with this short introduction, let's go back to our course director sir and start you, sir.
Thank you, Dr. Omkar, and good evening, everybody. I think this is one forum which has sort of grown on itself. Everybody contributed, but I think contribution from Emcure, the support from Emcure, and contribution from Dr. Omkar Swami has been tremendous. And I think we are on 22nd meeting today? Yes. Yes. So, who is presenting the first one?
So, Dr. Niranjan would be present.
Okay, Dr. Niranjan, over to you.
Good evening, sir. Good evening, Emcure people, for giving me an opportunity to present this case. So, it's a short case. Shall I share my screen?
Yes, please.
Is it visible, sir?
Yes, yes.
My case is actually a short case which we have done 2 years back in our CCU. Our CCU is at a peripheral center out of Bangalore. So I am going to present one case where we have done angioplasty for an anomalous RCA with a diagnostic catheter, regular diagnostic catheter. So here is a history of the patient. We had some 68 years old male presented with chest pain of lasting 4 hours. Is a known diabetic and hypertension. So he had vomiting 2 episodes. On examination, he had a heart rate of around 76, vitals are stable, BP is stable. ECG showed mild ST segment elevation, just 1 mm in inferior leads. And regional wall motion was there infra-posterior as well as lateral wall. Ejection fraction was around 30 to 35%, troponin positive. We loaded him with loading doses, tecospirin, ticagrelor, rosuvastatin, as well as heparin, and took him to cath lab. It was in the evening hours, so I was out of the hospital again, back to the hospital. So because they were willing for the primary plasty. So this is the left shoot where there is not much significant lesions in the left system. This is spider view. And in the left view also we went ahead with the femoral route because wall motion was in inferior, posterior as well as lateral wall. That may be LCX also, there may be a lesion in LCX also or RCA. So we preferred femoral route. And surprisingly, it was anomalous in the left system also. We could hook with AL1. So then I tried to hook right coronary. So because nothing significant in the left system, I tried to hook with the right coronary with different catheters, right Judkins, not possible. I tried to hook with the AR1, AR2. It was not possible. By the time patient started complaining of pain in the groin, we took a groin shoot. The groin shoot was, there was the tortuous femoral artery and external iliac artery. So anyway, it was not hooking in the femoral root, patient complaining of pain in the groin. We preferred to go to radial route, right radial. In right radial also, I directly took a right guiding Judkins right to hook it, but it was not at all hooking. And I even tried with AR catheter. It was also not hooking. That shoot was not taken. And finally took a Tiger catheter and it was non-selectively, it was hooking. By this time, even patient started complaining of pain because of the spasm of the radial artery. So I preferred, there was no way changing the catheter again and again. So finally I thought of trying with the Tiger catheter itself, diagnostic catheter, 5 French. It was an N catheter. Finally, I non-selectively hooked the RCA and passed the guide wire through the Tiger catheter, 5 French diagnostic. Took an N balloon, dilated the RCA from proximal to mid RCA. There was a lesion, tandem lesions. And finally tried with 3.537 mm biomime stent. It could not go. So a vessel was 3.5 mm. So I took 3 into 37 mm biomime stent deployed from proximal to mid RCA. Actually, all these things we took like fluoro we can make out, but while injecting, the contrast was less. When hardware was inside, contrast visibility was less because of the diagnostic catheter we were trying. This was the result after the stenting from proximal to mid RCA. So there was a lesion in the proximal segment, residual lesion. So we took another stent 3 into 16 mm biomime overlapped with the distal stent. Dilated, and the segment, overlapping segment was post dilated with N balloon. We took 3.5 mm. We could take 3.5 mm easily, and the whole of the stent in the proximal and mid stent post dilated. This was the final result. After the stenting. So whole procedure we completed with Tiger diagnostic catheter because we could not hook any other guide or diagnostic to the RCA from right radial approach. So I think in the take-home message, in the primary angioplasty, if the coronaries are anomalous, N catheters are preferable, which can be used as diagnostic as well as guide. When we suspect anomalous origin of coronaries, of any side, left side or right side, we can take directly the N catheters so that when no other catheters are hooking or any issues of spasm is there, we can do procedure in the diagnostic catheters also. And 5 French diagnostic catheters can take up to 3 millimeter stents and 3.5 millimeter balloon, N balloons. In case of anomalous RCA, angioplasty with Tiger catheter can be possible if guide and diagnostic catheters fail to hook or gives a proper support for the procedure.
Dr. Niranjan, very well done. Can you tell us a little bit more about the cross-sectional areas of diagnostic catheter and the guide catheters? You can talk of 5 French, 6 French, and 7 French. All three, diagnostic versus.
So 1 French is equal to 0.33 millimeters, sir. When if it is a 6 French, it can take it's 2 mm internal diameter will be there, sir, for 6 French. So
anyone else, Dr. Srinivas or Dr. Jabir? Guide versus diagnostic catheter.
Yeah, generally what we need to understand, Niranjan, is basically the guide. We tend to think that because it is more kink resistant, it has more thickness of the wall. It's not so. Actually, because of technology braiding inside, the inner lumen of the guide catheter would be more compared to the diagnostic catheter. Diagnostic catheter inside lumen would be less. Suppose same 5 French, the diagnostic catheter has a lesser lumen compared to 5 French of right coronary guide catheters. And that I think that's what Sir is stressing.
Yeah, I was also surprised, sir, but when nothing was hooking.
Yeah, I'll come to that. I'll come to that. This is the second commonest anomalous position of RCA in the regular day-to-day practice. Okay, there is no question of it not being hooked with the guide catheter. It's only a question of your comfortness and what you try. Generally, the commonest position of RCA which comes is just besides the left, and it gets best hooked in the radial position with same OptiTarc catheter. Slight torque if you give, it goes and just sits there in the anomalous position. The next commonest is it is not exactly in the right sinus, but comes slightly above the sinus, and that's what it was. And the best way to hook this catheter is the catheter which points down. The catheter which is pointing down will be Amplatzer catheter. So generally, Amplatzer catheter, there are two ways of hooking the Amplatzer catheter. One is to make it really Amplatzer, where it goes up and points and hooks. That doesn't work in this sort of things. Here, what works is you make it point down, and how your OptiTarc sat down like this, that AL catheter also will sit like that in this. And there are many times we performed angioplasties in this sort of thing. But it is a question of how you are comfortable in handling the Amplatzer catheter also. It's not very easy sometimes. and a large root is there and a large aorta is there, sometimes could be challenging. But anyway, you have shown some other
I tried
method.
with Amplats also, sir, but
Yeah, that's what. Sometimes it's a question of handling the Amplats catheter. When it is hooked with diagnostic catheter, by and large, it might be hooked even with the guide catheter, because guide catheter has obviously better support and sits well. It is very rarely, very abnormal location. Sometimes it could happen when you are not able to hook with the guide and only diagnostic catheter start. Many times it is the other way. The diagnostic catheters won't hook and the guide catheters goes and sit there because they have more stability. But anyway, you have taught us, you have shown that even in guide catheter, you can use angioplasty and do stents up to 3 mm diameter. But sometimes, if it is at least you should use all N catheters, because if it is G, again it gets choked inside and stents remain in the guide in the catheter and only balloons come out. So because of friction inside. Other thing is the lesion locations. What you thought? I thought it will be focal mid RCA lesion, at least whatever I could see it, and then proximal one. What you thought is again residual thing. I thought it could. It's not that important lesion to stent, to put a second stent. Every mild irregularity need not be stented. Okay, unless you feel it is important or flow limiting, something like that. So we would have left with a short mid RCA stent, if possible, especially when the origin is anomalous and you're facing challenges. I try to keep the stent size shorter and try to do a quick job and come out, unless you're forced to use long stents because of dissection or something. Those are some of the learning thoughts which came to my mind. I thought I will just share with you. I think Jabir can.
It was showing around residual around 50 to 60% lesion was there in the proximal segment, sir. So I thought.
Even if it is 50 to 60%, you are not supposed to stent it, unless it is just adjacent to the proximal stent where you are confused whether the dissection associated and all that. Every minor irregularity we need not stent. Okay. And especially in the acute MI scenarios, I feel very uncomfortable if you're putting two stents, long stents, overlapping stents. Always is it, as you understand, no, the chance of stent getting into trouble, thrombosis, all could be slightly more in the acute MI scenarios compared to the stable patients. That's why, especially in these troubled times of anomalous origin, diagnostic catheter, unless it is absolutely essential, don't take a long stent and you need not cover all the mild lesions. This is only for learning, you are saying, don't get us wrong. Okay,
Dr. Srinivas, I would entirely agree with you that don't take long stent. Whenever guide catheter seating at the ostium is not going to be very stable, I think taking long stent is never a good idea. You could put two stent to cover up that length entirely. However, Dr. Srinivas, I would probably feel that next time this gentleman has a problem from the right coronary artery, it would be another huge effort for whosoever is going to be doing an angioplasty. So I would feel that 50-60% lesions, I would probably stent in this case. And that too, the lesion was proximal to the stented site. So if it grows again, the whole effort is going to get wasted. So I would probably feel that more complex the scenario, probably put long length stent and make the vessel safe for a long time.
But original lesion looked very focal now, sir, in the mid RCA.
No, there are two tandem lesions were there, sir. The proximal lesion started after this stenting. It was like other view I didn't show. I didn't show.
Maybe we didn't appreciate because views were limited in what you showed, but it looked like a focal mid RCA lesion to me.
Tiger diagnostic catheter, and what is the closest guide catheter that you get in the similar shapes?
Medtronic has a catheter which can engage both right and left, sir.
Icari right and Icari left are there.
Yeah, that is what.
It's almost similar to that of a Tiger. And in fact, there was a chimney catheter. I have not used it. There are guide catheters that looks exactly like that of the Tiger.
Yes.
I have never done an angioplasty to a diagnostic catheter. So it's a new knowledge for me that we could pass a 3 mm stent through the diagnostic catheter. But as you rightly pointed out, if a diagnostic catheter can hook a vessel then a guide catheter. There must be a guide catheter which can hook the vessel, no doubt about it.
No, but Dr. Niranjan, I want to ask you, when you said you wanted to do angioplasty with a diagnostic catheter, did you know that the stent would go through the diagnostic catheter?
Yes, sir. I had tried this one with a diagnostic catheter for the RCA earlier, sir. When, that case, time permitted would have shown 5 French diagnostic N catheter when the patient arrested with a complete heart block, not thrombolized. Thrombolized. Even after thrombolysis, patient arrested after 3 hours, took for angioplasty with the CPR to the cath lab, sir. That time, when I took left shoot and then right shoot, diagnostic only directly I could, it hooked, and through that I passed the wire, sir. After that, rhythm immediately started with the diagnostic only, and that day also I did with diagnostic catheter. That was a that was 3 mm vessel, sir. I could pass the 3 mm stent. With that confidence, I took this case, sir. That case.
All three of us, Dr. Srinivas, myself, and Dr. Jabir, are probably not. We probably haven't done angioplasty through a diagnostic catheter. While you already at this young age, you have 2 cases where you have done angioplasty through a diagnostic catheter. That is very commendable. But is it particular stent that goes through these diagnostic catheter? Because routine stents don't go through these diagnostic catheters. So I would probably feel
it will be very difficult, sir, because
which stent did you take?
I took biomime stent only, sir.
Biomime. So what is the strut thickness of biomime?
Biomime is around 85 to 90, I think, sir. 90 around.
I have no much idea. But anybody, Dr. Jabir or Srinivas or anyone for that matter?
The older generation biomime stents are really stiff stents. It's very difficult to track
newer generation stents.
It must be a newer generation biomime stent.
No, but what is the strut thickness?
That I think it is a 72 microns or something, the new generation. Previously it was 85 or 90. It was a thick and a very tough, what you call a stiff stent. But now the new one is, I think it is more trackable.
The thing is, this case I would have gone with the guide catheter itself. So then I failed in the femoral route. Three catheter complaining of severe pain. Radial route at the second and third, the second catheter itself, he was complaining of spasm not relieved. So I thought of doing with the diagnostic, try with the diagnostic. So at least even if balloon dilatation happens, balloon goes N balloon. But luckily stent also went. So
the other thing I would like to suggest, I don't know whether you all agree or no, whenever you have this kind of situation, put a wire through the diagnostic catheter and get the diagnostic catheter out with the support of an extra length wire. So you would probably have a long length 014 wire which goes into the coronary, and you take a 3.5 or 3.8 wire which is going to be double length, and this you put it in the aortic sinus. And over these 2 wires, you bring the diagnostic out, and then you mount your guide catheter to take your balloon and stent and the rest of the material. So that also could be a good idea if earlier diagnostic guide were not fitting and diagnostic fitted well, and you could do this. The other question, Dr. Niranjan, I wanted to ask you, did the ECG give you a hint that the infarct is coming from the right or from the circumflex?
No, the ECG didn't give any hint, sir, because but echo-wise, I could say inferior, posterior, and lateral was also hypokinetic. Thought maybe LCX also possibility was there. It is almost like an NSTEMI. So if LCX lesion is there, then from radial route will be difficult, maybe tortuous LCX. So I preferred the femoral route initially, but there was a tortuosity in femoral and external iliac. So it went into, he started complaining of pain when changing the catheter. I could know left system is fine. So when I did the diagnostic with AL, then I took the radial. Radial also, the guide I directly took, RCA guide, but guide didn't hook. Then I tried with AR also didn't hook. And thirdly, I took take a shoot with Tiger. So it somehow hooked non-selectively, passed the wire. And so, because that time he is shouting with pain, patient, so I could not do anything. So whatever hooked, I tried with that.
No, very commendable because it saved time. And I'm sure if you had to change to guide catheter, you would have spent another 15 minutes. And here the patient was already shouting with pain, so it was an intense pain. The other thing I would...
Actually, I thought of that, sir, but we didn't have double length wire on the shelf, sir. So the single length
the other thing I would suggest is when you have such a difficult access, your stent has gone into the correct location. While deploying, don't go to high pressures because that's the time you would dissect, and taking another stent through this deployed stent would be very, very tough. So I would probably take the stent balloon to a pressure of just around 5 or so, take it out and take a short NC balloon and then dilate the whole length. So you are not outside the stent area at all when you are doing a dilatation, because dissection would be that is something which I would feel is important when you are dealing with a very difficult access. Also, you joined the two stents or they were away from each other?
I overlapped, sir. Just
overlapped. I think that is also a good idea, because if you overlap, you are creating only two ends. While if you keep the two stents separate because you feel the intervening area is normal, you are creating 4 ends to the stent. And 4 ends will never allow you to go on a very high pressure comfortably. So if you have only 2 ends, you can go very high pressure, take whatever non-compliant balloon and whatever high pressure you want to use inside them. So I think joining the 2 stents and not leaving, say, 3-4 millimeters gap between the 2 stents is generally a good idea. All right.
Okay. Thank you.
Any other comments?
Sir, regarding the biomime stent, newer biomime aura stents have got ultra thin strut thickness.
Correct, yes.
62 something like this, 64 something. So these are actually very compliant stents, unlike the earlier biomime stents, which were very big. You know, I think the stent choice was excellent because he was going through a different approach through a diagnostic catheter. So perhaps biomime stent was very apt in this situation.
Orsiro has been found to be a very
62. Orsiro is 62.
62.
That is one of the thinnest struts.
And biomime aura is 64.
That Genex Sync is 65. Most of these premium stents are 72 to 85 microns.
Yes, sir.
80 to 75 microns. The synergy is two type. Depending upon the stent size, the synergy strut thickness varies, but by and large, it is between 79 and 82, 83.
So almost all stents will be around in this 70 to 80, sir. 60 to 80. So that you can...
Have you tried with the Icari catheter also there?
No, sir, we didn't have Icari catheter here.
Doesn't have it.
Another thing, if it is close to the left sinus, apart from what catheter Dr. Srinivas has suggested, through the right radial, you can use a left Judkins and curve it. it may go. If it is, this is a downgoing origin of RCA, you cannot use it. But if it is an up origin of RCA, which is close to the left main, then you can use it. If
You are suggesting
multi-purpose, sir?
Not multi-purpose. Multi-purpose is basically for a downgoing lumen.
So you are suggesting which catheter?
If it is an upgoing RCA, aberrant origin, which is close to the left main, if our implied C is not helping, another catheter is the left Judkins to the right radial and curve it up.
Actually, this we see sometimes when we go from the groin also. You're trying to cannulate the left and the catheter hooks into right. So the right and left origin are very close to each other, probably in the left sinus. And that's why a left JL catheter sits very well at the mouth of the anomalous originating RCA from the left sinus. So very good. Actually, it's very frustrating when you have primary angioplasty and you are struggling so much, once groin, once radial, and yet not able to approach. I think what you did was tremendous. That whatever catheter fitted, you used it to get your wire down. So once you achieve a stability, you had enough sort of options. But I would have felt if it was a difficult lesion, which needed more support, more deep engagement of the guide catheter, I would have probably changed it using a long length 2 wires. All right, any other comments, or we can move to the next case, Dr. Onkar?
Yes, sir, we can move to the next case with Dr. Salil Vaidya.
Thank you, Dr. Niranjan.
Thank you, sir. Thank you very much, sir, and Srinivas, sir, for your wonderful teaching.
Okay, Dr. Salil, we are waiting for you.
Are you able to see my slides?
Yes.
Good evening, everyone. After a wonderful case by Dr. Niranjan, I'm going to present a case of calcific left main angioplasty, which we did recently. So this was a 72-year-old gentleman, hypertensive, non-diabetic, with history of dyslipidemia. He came to us with unstable angina for last 2 weeks. On evaluation, he had a normal LV function. His TMT was very strongly positive. We took him for diagnostic angiogram. The initial fluoro view shows that there is a significant calcium in the proximal LAD and proximal circumflex. The initial RAO caudal view shows that the patient has very critical distal LMCA occlusion of around 90%. Proximal circumflex, which is very dominant vessel, shows around 80% lesion. There is some mild disease in the OM. The LAD also shows long segment disease up to mid LAD. This epicranial view shows that there is some disease in the distal circumflex, and it's a very dominant vessel. The disease in the LAD is extending up to mid LAD. Distal LAD looks quite clean. This spider view shows quite a wide angle bifurcation of LAD and circumflex with significant calcium in the proximal LAD. So this was a case scenario where the patient had intermediate syntax score, and we discussed surgery as an option with the family, but they did not wish to go for surgical treatment. Hence, we decided that we will go ahead with angioplasty. So, to review, these were our target lesion: mid LAD, proximal LAD, LMCA, distal LMCA, and proximal circumflex. So we decided that we'll use decay crush as a bifurcation strategy. We'll use IVUS for assessment of calcification, and we were sure that this patient would require some form of debulking, ROTA as well as OPN. So we were with the 7 French EBU catheter. Most of the times during our complex cases, we take help of long sheath as we believe that it gives a very good support. And we are in with the IVUS catheter. The IVUS run from proximal LAD back to left main shows a very significant, almost 180 to 270 degree calcium in the proximal LAD with a very tight lesion in the distal LMCA.
The other important issue, Salil, is the left looks very dominant circulation.
Yes, it's a very dominant left circulation, sir. So we went in with ROTA 1.5. After carefully debulking the distal LMCA and proximal LAD lesion, we shaved off all the way to mid LAD. And after giving lots of vasodilators, we got a decent result with ROTA ablation. Now, ROTA wire was exchanged with a microcatheter and trapping balloon to a regular run-through wire. We pre-dilated the mid LAD with 2.515 NC balloon. We took a 338 Zions expedition stent for our proximal to mid LAD lesion. All this time, we did not wire circumflex. Now, after wiring circumflex, we decided that we have to treat circumflex and circumflex osseum and debulk it very aggressively. So we pre-dilated it with 315 OPN NC. We went up to almost 35 atmosphere, going up gradually from 20 atmosphere by 1 or 2 mm slowly. Now a 3518 stent was taken, just stopping short of OM bifurcation with 2 or 3 struts back into the LMCA. Stent was meticulously placed with a balloon in LAD. After deploying the stent and post-dilating it with 3.5 NC, we did a check shoot to rule out distal dissection. And circumflex wire was removed. Now we crushed the circumflex stent with 3.515 NC balloon. So this was the first crush. The rest of the LAD stent was dilated with 3.0 NC balloon. Now a regular wire was crossed through proximal cells of the crushed circumflex stent. And first kiss was performed 3.5 stent balloon in LAD and 3.5 NC balloon in circumflex. We again removed the circumflex wire and 433 Zion's expedition was taken. In eleocranial view, we placed it at left main ostium, making sure that it is covering well with the LED stent. Now, after deploying the stent, we took a 4.58 NC balloon for pot. After pot, we got a very good result. Now again, circumflex was rewired and a second kiss was performed with a stent balloon of 3.5 in circumflex and 3.5 NC in LAD. And finally, repot was done with 4.58 NC balloon going high up to 20 atmosphere. So this was our final result, which was quite pretty. So this is what we did. We put a LED stent first, then we put the circumflex stent. We put a left main to LED stent the last, and we did this by decay crush technique. So planning helps a lot to do such complex PCI, and it is always a teamwork. Appropriate use of debulking technologies like rotablation, OPN balloon is very important, as it helps to get good, helps to get the bed prepared very well and to achieve good stent expansion. Usually we would like to use good stent which would have good radial strength, so that long-term result is good in such calcific vessels, and decay crush in such scenarios is a very good bifurcation strategy. Thank you.
Very well done, Salil. Can you tell us a little bit more about OPNNC? You used OPNNC to predilate after doing the rota, right?
Yes, sir.
So, I mean, I also like it very much, and it has 2 layers. Very important that even the NC balloon which we take and we go for high pressures, like when we go from 15 to 30, the diameter will always increase at least a little bit, while in OPNNC, the increase in the diameter is very minuscule. And that's why I think the hurt to the vessel, the possibility of a rupture, even at high pressures like 45 and 50, are not there. So I would probably feel that that was a very important thinking. The other important issue is the entire circulation is left dependent. I mean, you see a huge circumflex territory. So do you think we should put a balloon pump as a precaution, or just take an access from the opposite groin for possible balloon pump as an emergency?
So as this patient's LV was quite good, we just took a contralateral puncture and put a 5-thread sheath in it. But if the patient have had LV dysfunction, then it is always good to have a balloon pump in first and then start with angioplasty.
Dr. Jabir, what are your criteria for putting in a balloon prophylactically in a difficult coronary lesions. Dr. Srinivas, maybe if Dr. Jabir is not around.
Yeah. No, but as I said, sir, patient, if he has associated LV dysfunction, then probably in that scenarios we would do it. And where you expect little complexity like this, you are trying to do rotablation, and then probably you need two-stent technique, bifurcation, all that. Then you need to be little more careful and probably take the help of IBP. Though data shows many youngsters must be thinking data must be showing negative with IBP, but it is individual patient is different. You can't randomize produce the data with IBP, but many of the times, at least it gives us a comfort level to operate and during the procedures. And it helps in such cases, especially when there's LV dysfunction. But as you said here, if LV function is normal, many of us may still get away without using balloon pump also. And another situation where we use in patients of acute MI with borderline pressures and then patients getting arrhythmias in between also, you tend to use balloon pumps, ABP. Those are things I can think of. I thought this case is done by you, sir. You are asking a question.
And Salil work together, but so many times I've been working in two labs, so they are doing almost 80% of the work.
But it is greatly done, sir. The case demonstration was it was excellent way to do it. Some of the points which out of this thing he didn't highlight were, for sake of again listeners, what I thought is bed preparation by rotablation, and again, if the still is not totally ideal, then usage of OPN balloon to further dilate it better. And then other points which showed why LCX is taken OPN balloon, why not rotablation also to the LCX. People must be thinking whenever there's acute tortuosity, angulations, again, sometimes you could land in trouble with rotor bursts, burst stucking and all that problems. That's why I think OPN was selected.
What do you think, Dr. Srinivas? The LAD was, I mean, I'm continuing your last point of doing rota to circumflex along with LAD. Two important circulation if you do rota at one given time. And patient is hot case like he was getting recurrent angina. I think I would probably do rota to the most difficult calcified.
Yeah, that's what I'm telling, sir. That's what I was telling. That's why OPN balloon was used that side rather than doing rota. That's what I was also mentioning. Not to do compromise in both places. And that's how you demonstrated. He didn't highlight that point. That's why I was just mentioning. So some of the things which were done very well. Other thing which he showed is a left main coverage. You took left cranial view very well. Documented that ostium of the left main was covered well. It was shown well in the elevocranial view. Always position the left main stent ostium covering. Better to always check in the elevocranial view. That also you showed it, but didn't highlight it. But
actually, again, Dr. Srinivas, this left main ostial position of the stent, it has to be achieved 100% because you are going to dilate that area with a very high pressure balloon dilatation. And if you have no metal there, if you miss the ostium, it could create a lot of problems. So I think that epic elevocranial, which you took, in addition to, I'm sure you take a shallow areocranial and also a spider. Probably these are the three views which you take to get a left main ostial position. I think the angle which you used, elevocranial, is perhaps the best angle to know the ostial position of the left stent. Always make it a habit to project it a wee bit outside into the aorta so that you can go high pressure and not miss the ostium at all. I mean, when you do balloon entry with a non-compliant balloon, after you remove the stent balloon, that sometimes has to be carefully managed. So when you are trying to take out the stent balloon, that's the time you must engage your catheter. So your stent balloon is here, you want to take this out and your guide catheter is here. So when the stent balloon is there, get your guide catheter in so that it's along the stent balloon. And when you pull out the stent balloon, the guide catheter is well inside the stent. I mean, lumen-wise, It is, if this is the stent, your guide catheter is exactly like this. I mean, if you don't do this at this time when the balloon is inside, and then you try to engage, the guide catheter could hit the stent either here, and will probably not be well aligned. So that was another thing which one must do when you are stenting the ostium. Get the correct ostial position, but retain the guide catheter in that correct lumen throughout subsequently for whatever you are doing. You may be doing imaging through IVUS, you may be doing post-dilatation, you may be doing POT. All these could be easy if your guide catheter is well positioned. And then, as Dr. Salil described, a repot or a final pot, again, very important. I mean, you do a first pot to access the side branch with a wire. Then you do kissing and all those things, but finally must end up with a final pot. When you do a kiss, you have two oval kind of openings in the stent. So the final pot will correct this and make a single stent O opening. And that is very important for future procedures as well as stent healing. Any other comments? Dr. Jabir? So in this particular case, Salil, you had a very dominant left circulation, and you were still quite confident of doing rota to LAD and doing a TK crush, which is perhaps one of the best stent strategies in long term. But doing it short term requires, I mean, during procedures, there are a lot of extra steps that you take during these procedures. So I think on all these fronts, this was a very nice, very gratifying result. Dr. Jabir, you want to comment anything?
I think almost all points are well. You both of you have covered it very well. A very nicely done case. Actually, it's a time bomb with a very dominant very dominant circumflex tight left main disease, calcium. Especially, I may be a little bit afraid, as you said. I may also be a little bit afraid to do a rota. What mechanical cardiac support device most of us are having only is IABP. So it is an upfront use of IABP if there is LV dysfunction, if the LV is normal. But here only problem is the entire supply to the left ventricle is the left system, and you are completely cutting off the supply to the left ventricle. You can go and arrest.
And so many times. Every time you balloon inflate, you are doing that.
Yeah, mechanical cardiac support, whatever mechanical cardiac support available with you is likely to benefit. So I think a perfectly done case.
So what is your advice to all of us, this kind of case? Put a aortic balloon pump beforehand, or the way Salil did it?
If there is a LV systolic dysfunction, I'll use a mechanical cardiac support upfront. If there's no LV systolic dysfunction, then as Dr. Srinivas was telling, I may keep it as a reserve or I may not use it.
I would probably feel in a similar direction because, I mean, you have to come out with a perfect result on this case. The stent expansion has to be absolutely beautiful, has to be demonstrated very successfully towards the end. And for this, if you have a balloon pump, it would probably add a lot of comfort while doing the procedure. And you will probably not be very hesitant to use long duration inflations, higher inflations with a bigger diameter balloon. So all this is possible if you are quite stable and you don't have to rush through the case. Apart from that, I don't think balloon pump will probably serve too much purpose. Adds a lot of extra steps also.
And this is one situation where you can remove the balloon pump on the table immediately after the angioplasty.
Yes.
And
You
make
may not
sure
even start pumping it. I think
and
you
make
can
sure
just-
people like Hiramat are available when you are doing such case. Because just because you start off and some problems happen, you should be able to tackle. Operator experience is most important
Yes.
in tackling such cases. Though we have good data coming up, but you don't start off unless some good help is available. Teamwork also goes a long way in doing such complex cases. Obviously, you must have done IVAS also post procedure, which is not shown, I think.
Yeah.
That's also important to document, as sir said, a perfect result and demonstrate again with imaging technique that it is done well is very important. Sir, in today's era, which are the case which should patient request and all is fine. Which are the cases which you would like to send for CAPG? Because I feel pity for surgeons, left dominant system, distal LAD, middle LAD disease, left main disease, LCX disease. Still, I would do the same. If patient requests, I would do the same. I'm not denying it. But I'm saying upfront where you would like to send the patient to surgery.
In this particular case, actually, the history of a recurrent angina was also there. I mean, 15 days before the procedure, this gentleman had angina again and again. So I guess we should consider a possibility of some degree of thrombus. And doing that rota was obviously a little bit of a challenge. I mean, if we had run into no flow, slow flow, it would have been very, very hard to come out with this kind of result.
Probably in today's era, sir, I
So-
feel if a patient has 2 CTOs, okay, CTO of LAD, CTO of big RCA, that's where I think we could still send the patient surgery. But if you're confident of revascularizing the patient totally, any sort of lesion, still you could do PCI. That's a broad guideline I think we should take and suggest.
No,
Well,
Dr. Srinivas, in these kind of 2 CTOs, double CTOs, many would do 1 CTO today and leave the other CTO for 3 weeks later. And
so that means you will not send any patient for CABG then.
No, there are a lot of people listening to you and I. And
that's what I'm
Dr.
saying.
Jabir,
So if a patient has 2 CTOs, I feel there's more artery, more myocardium at risk. And that is why I think that are subsets of patients where immediately I can think of, because left main anyway you're doing it nowadays. So I think 2 CTOs and otherwise where the anatomy is not very clear to where to land the stent, because the proximal zone, distal zone is not very clear. Sometimes there's a chance of dissection of the stents. And if you're not comfortable revascularizing again totally, those are subsets of cases where you should think considering CABG. Another thing is left main. Many times ACS, acute MI, people keep telling for CABG, it's not easy to do CABG in acute MI cases. Always try to do like, even if it is other vessel occluded also, as sir said, probably in acute MI phase, you can tide over by doing a culprit vessel PCI and think of stabilizing the patient and then think of doing it. Sending a patient for CABG in acute situations is actually not good. And many times the surgeons also would land in trouble. They won't like it also. They will also curse you, but if you're giving a case, if you give it, and these patients could land in trouble. That is another scenario, I think, where we could actually practicing percutaneous procedures more in spite of difficult anatomies.
Let me tell you one. The case I sent for a CABG today, emergency CABG.
This gentleman had.
This patient, not done by us, some 4 months ago, he underwent a left main angioplasty bifurcation with 2 stents in LAD and 1 stent in RC, 2 stents in RC.
Restenosis, you're saying?
Extent, whatever restenosis, left main ostium 90%, circumflex totally occluded, LAD 90%, RCA ostium 90%, recurrent chest pain with ECG changes. It's a time bomb, we cannot touch him again.
Yeah, so secondary stenosis anyway is different.
That's a situation where I think we should not go and do a stenting again, unless to stabilize the patient.
Yeah,
if the patient crashes on the table, we may do something.
Yeah.
No, even if you stabilize this kind of patient, I don't think we should do a re-angioplasty in this case.
Yes, agreed.
Because you have severe ISR and you will never be able to expand a stent the way you want on OCT or IVAS imaging. So I think once ISR for a left main bifurcation, I think surgery is my personal choice. I would probably not do repeat stenting unless, I mean, we have done some cases where only the circumflex was requiring a help. and things like that. So that is a possibility. But in general, that is a case for surgery. So, Dr. Srinivas, you did not include this
The second,
ISR into
I
your
think that
thinking.
second indication I forgot
ISR.
actually is like such sort of thing where the patient has developed interstitial stenosis. But what clinicians are doing nowadays is if it is a straightforward lesion, still they would stent second time, and third time they would send for surgery, but not for left main bifurcation. But left main bifurcation, as you said, I don't think we need to do it even the first time also. Immediately a patient has restenosis, probably you should send for surgery. But LCX ostium, again, many times people do only drug-eluting balloon and try various methods because LCX, LAD is all right, left main is all right. Only for sending surgery for LCX, it looks painful. So as you said,
in fact, I would go one step further. I was attending one of these small sessions in the side hall in TCT, and the L6 ostial ISR, the left main to LAD was functioning very well. And one very reputed interventionist said that leave it for medical treatment.
Yeah, that's
leave
also
it for medical treatment. So ISR to L6 ostium is something which is very difficult to address. So if that LCX is like Dr. Salil Vaidya's case, a hugely dominant vessel, go for it. But if it is like a conventional RCA taking care of most of this circulation, I think medical treatment also is a reasonable option.
Yes. You will go for third case, no?
Yes.
Yes. So Dr. Nabajit Talukdar will be presenting third case. Over to you, sir.
Yeah. Do I have the share option now?
Yes, yes.
Are the slides visible?
Yes.
Well, to put it straight away, this was an 82 years old male with history of angina on exertion, culminating in recent ACS. This was in October 2020 on the background of tailing end of first wave of corona. He was on impending shock and treated elsewhere. Drops were more than 1,000. Hemoglobin of 11.9. He had a moderately higher degree of creatinine of 1.6. Euglycemic. ECG showed anterior ST depression and anterior legs. There was moderate LV dysfunction, but no MR. Chest X-ray showed PVH and some shadows. Clinically stable since past 7 days. He arrived at us with BP of 110 by 70 and a pulse rate of 100 per minute, resting saturation of 96. He was, pre-procedure, we used to take COVID-19 test. He was found to be RT-PCR positive. CT value was 19. HRCT done showed 40% lung involvement. And on the day of the procedure, his SpO2 was 92. So this was the right shot, which showed some mild to moderate disease, which was okay, did not merit anything. The real game was on the left side. There was a roomy left main, and there were significant lesions starting from the ostia of the LAD, causing slow flow in the LAD, and also significant lesion in the circumflex. This was the crab view. Now, we can see the circumflex just after the ostia was tapering into a very tight lesion. The LAD was also irregular. We decided to go for double stent strategy and wired both the vessels with BMW wire and pre-dilated initially the circumflex with a 2.5 into 12 mm balloon. Then went to the LAD. The initial dilatation was by a 2.5 balloon followed by a 3.0 balloon. So after the initial dilatation, this was the flow. Then we took 2 stents. We decided that we were toying with an idea of what stent strategy to go. We decided that we go for the V-stent strategy because in one way it was corona positive. We want to conserve some time, as well as we wanted to make the procedure simpler. So on the LAD, we took a 3.5 into 32 Yukon Elite stent, and on the circumflex, we do a 3.0 into 28 Yukon Elite stent. This was on a different view. We were aligning the stents, and then we dilated both the stents in a V fashion.
Can you tell us a little bit more about this dilatation? How you, once you position your stent?
The Yukon stent has a typical thing. It dilates from the ends. It dilates from the ends. So the dilatation process in Yukon stent has to be more in a staggered fashion, 2, 4, 6, 8 type of a thing. So we dilated it in a likewise fashion, taking care not to taking care of keeping the guide exactly in the position so that we don't wanted shifting of the balloons, and my operator, my helper, and me, we were dilating at the same time. Then after that dilatation, we went to the post dilatation of the circumflex stent with 3.5 into 8 balloon, dilating up to 16 atmosphere pressure. I'm sorry, this suddenly got stuck. Then we dilated the LAD stent with 3.5 into 8 balloon. We, of course, going to a higher pressure. Now we decided to go for a kissing strategy. For the kissing in the LAD Ostia, we took a 4 into 8 NC balloon, and on the circumflex, we retained the same 3.5 into 8 balloon. So this was the position of the balloon. We took the help of stent boost, and we ensured that there was no overhang, etc. And we went to the this thing, final kiss at the 18 atmosphere pressure. So following the kiss, the results were quite gratifying. This was the shot. This was another view. We were not sure what this thing was there. We took an OCT run to see if there was any defect, dissection in the left main. The OCT was more or less okay. There was some malapposition at this point, which we also post-dilated. But there was no dissection, etc., in the left main, and somehow we did not intrude too much into the left main, maybe a 1 millimeter intrusion into the left main. We thought that we managed the case well, and that was the end of the procedure. So to conclude, distal left main remains one of the holy grails of intervention. Planning, details, hardware selection, guide control is of human importance. Backup mechanical support might help. Restenting is still relevant in some cases, and imaging by OCT or IVUS use is imperative. However, I must stress in this part that his patient was also COVID positive. The previous hospital where he went for an NGO, that time the COVID was negative. In the 7 days intervening, he somehow developed, or maybe it was an intercurrent thing. Delhi was undergoing a huge rush of COVID cases at that time. And we had to take cognizance of that system also, because he had 40% lung involvement. So I just end it, and I am honored to present this case in front of Dr. Hiramat sir, and of course the learned Javil sir and Srinivas sir, Please give me tips how I could have done it in a different way, or in where I can improve more. But the patient on 6-month follow-up had done very good. There have been no been angina on exertion. In fact, his creatinine is improved. The ejection fraction is improved. The LV internal diameter has decreased. He is currently on DAPT, aspirin plus ticagrelor, with rosuvastatin of 40 milligram, metoprolol of 50, and pentoprotein pump inhibitor. In the initial part, because he was having COVID and appreciable lung involvement, we had actually given aspirin, ticagrelor along with rivaroxaban of 10 milligram for the lung lesions. Initial 15 days, we put him on low molecular weight heparin, and then we additionally, till around 5 weeks, we gave him additional rivaroxaban. After that, we stopped the rivaroxaban. Currently, patient is on DAPT. We plan to continue DAPT till 1 year and then follow up. Thank you, sir.
Dr. Nambajit, that was very interesting, especially when the whole world, I think all of us, 3 of us, I, Dr. Srinivas and Dr. Jabir, we used to do a lot of these restenting, but I think as things evolved, many of these stents their techniques were replaced, and things like culottes, decay crash, these are the ones which we always use. But this is a very good thing that you used, like you had metal-to-metal contact, very well seen, perfectly dilated stent. The way you post-dilated with short non-compliant balloon was also very, very good. And I think we have to sort of maintain the back end of the B. Like one stent is coming up to here, second one is coming from here. So when you are post-dilating, you must get your balloon at the back end, go equal pressure. This is at least what I do. Go equal pressure, something like 10 on each balloon. Go one balloon full, like something like 30. Bring this down, go the other one to 30. Bring this down to 10, and maybe elevate both pressures to about 14 or 16, and then come out. So I think the way, I mean, you have a very good opportunity to go very high on pressure, and you must sort of give very high level, long pressure on these kind of leads so that they perform very well in long term. So we learned a lot from your case, and restenting, which is sort of fallen back in everybody's percentage of techniques that they use for bifurcation, is again brought back. The other important thing that you achieved, Dr. Nabjit, was the creatinine was high. So by using this technique, you avoided you avoided re-entry into the side branch, you avoided kiss and all those kind of complex steps. So you probably avoided about 10, 12 steps. Each of them could have taken some extra amount of contrast. So I think when you are dealing with compromised kidney function, a simpler technique always works better. My feeling is restenting is perhaps the easiest technique to do, and there are not many cases which are suitable for restenting. But if you can choose a case like Dr. Nabjit showed just now and if you do a very good job, as was shown by OCT, I think your long term would be as good as any different techniques of stenting. Dr. Jabir?
Yes, Nabjit.
Sir, here there were 2-3 things where I was plagued with. One was the coroner. You know, I had to somehow ensure and make sure my fellow that he has to be with me only for half an hour. I promised him it is only for half an hour. He was telling me, "Sir, क्यों कर रहे हो? Surgery में भेज दो." So patient was having pain. You know, that was a panic situation. That is number one. Number two is 1.6.
One minute, doctor. One fellow told me that I had promised my girlfriend that I'll be back in half an hour. So he chose a weak stenting instead of something else.
But sir, I think in Navjit, it is commendable in these tough corona times where family members are leaving their patients and not even coming near them, and human effort, and you saved the patient's life, and doing such complex procedure in a COVID positive patient. Did you get COVID already or what?
No, sir. I was lucky enough not to get
See
COVID.
that the God protects.
This procedure, I did it in 20 minutes flat. And
true, that's what I'm saying. God protects. If you did with a good intention, I think God protects, and still you didn't get COVID. And the masking, I think masking and the face shield is what is protecting us in cath lab. That's most important. And you should be
that thing, Dr. Srinivas, I would feel that cardiologists, they get excited with the kind of lesions. Like this was a very challenging lesion. And I would not let this kind of case go out of my cath lab. So many times I sign on the permission form that if patient does not pay, I'll pay. And I go ahead and finish the case, you know. It is such an excitement for us. So I would probably feel that you did a great job on a COVID positive case too, you know.
Yeah.
Sir, the other part was about anticoagulation. I had in this case, what I did, because I wanted faster things, I used a slightly higher anticoagulation thing. I kept the ACT near about 400. At the same time, I was quite afraid because COVID patients also bleed more. So I wanted to know that if from the learned audience that is there anything, this was completely my thought. I searched in the literature, nothing much was found in the literature regarding this. Is there any difference of anticoagulation strategy in a COVID patient versus non-COVID patient?
I think in this case, you mentioned the serum creatinine, but I wish you had calculated the EGFR also.
Yes, sir. EGFR was 53. We calculated it.
So that is clearly a moderate dysfunction.
Yes.
And I would probably feel that one has to be, I would probably use low molecular weight heparin many times when you are doing a procedure. So instead of using a big bolus of 7,500 or 5,000, I'll probably start with 3,500 and then keep using 1,000 again and again. So that you don't overdo anticoagulation. But what did you do with aspirin? I'm very curious to know that.
Aspirin, sir. Mm-hmm. Yeah, aspirin, we kept it because patient on the table, we loaded him with aspirin plus ticagrelor.
No, I would agree entirely the way you manage the aspirin. In first 2 weeks, it's totally justified. But there are a lot of studies where aspirin can be withdrawn at the end of 1 month. So
yes, sir. Of course, nowadays we have data. But this patient is 82. He had been doing well. I am regularly checking his antiplatelets till 6 months. He has not had any problems. So I am trying to do the dual antiplatelet for 1 year, and maybe after 1 year for another 6 months, I will use ticagrelor of 60 milligram twice daily.
No, don't do that. I would probably take out aspirin. I mean, we have enough studies which tell us that you can.
Sir.
Take off aspirin.
And all this, yeah.
Yes, so keep ticagrelor, same dose, full dose for first 1 year, along with whatever anticoagulation you have chosen, NOACs or warfarin. Warfarin gives you more options because you can titrate the dose more frequently, while most of the NOACs, you use a standard dose. And
Sir, NOAX I have stopped after 6 weeks. So now he is on
Yeah.
DAPT.
he's only on DAPT.
Uh,
All right. Okay, I think excellent learning. I mean, a technique which everybody says don't do V-stenting, don't do SKS. On that background, this case, your case, had a lot to learn from. And I'm sure the promise that you gave to your junior that you will finish in half an hour was also fulfilled in this case, because you chose a technique which did not read, recross, did not need too much fancy steps, and you still achieved everything that one would want to achieve, a full expansion of a well-deployed ostial stent. So congratulations on that front, and I'm sure the follow-up would sort of drive you. I mean, we are all trying to move away from stenting. We'll probably make an impact in your mind, and many of our mind too. Stenting is a simple technique, quick way to get out. So whenever there is a clinical situation which is very bad, like patient is in shock and things like that, I think just do these kind of techniques. I remember one of my colleague, the patient was so bad that he just did a V-stenting, came out, and next day came and corrected next day means after 2-3 days he came and corrected whatever was remaining. So on that front, you did a very complete job with simple steps.
Thank you.
Congratulations. And Dr. Srinivas, you want to add anything more? Or
No, like anatomy was also perfectly suitable, where you have an extension of lesion is not there into the left main totally, and you have a small normal segment and the tight lesions in the ostium just after the ostium of LAD and that LCX branch. That is ideally suited for this sort of a V-stenting, which is perfect choice for you. And that's how the result came out
Dr.
well.
Srinivas, I feel that many live cases that we see these days, if they had a lesion, very few would go for V-stenting. They would still go for a DK crush or culottes, those kind of things. So on that background, this was a very good learning for all of us.
When there is, when the situation, as Dr. Nabijit has done, something like when the patient is crashing or left main with hypotension, when the patient develops a hemodynamic compromise and you have to complete the procedure quickly, this is one option you can take. And we have re-endured some of the cases of V-stenting which we have done in the past, and some stents are still doing good. Some have developed significant restenosis. I only have one point to when I learned the V-stent technique, my trainer used to tell that once you do a V-stent, along with the stent balloon itself, you dilate it fully well and then never try to re-enter with a balloon.
Yes, sir. But nowadays we have excellent imaging facilities, and the stent boost system, if you use it correctly, it gives you a precise location. So, see, stent boost images, I did not put it here, but I took help of the stent boost images quite well. So I used two things. One was double mag, and then on top of it, stent boost. So stent boost also, you can do it with a little amount of dye and without a dye. When you do it with a little amount of dye, the delineation and the marking of the stents and the balloons become very well. It is truly marvelous. You know, it is almost like an imaging. So, so that is the way it is. One disadvantage of the stent balloon is the rated burst pressures and other things of the characteristics of balloon. The stent balloons, when you dilate it to a very high pressure, there is often some dog boning, because that is the concern why I did not go for the stent balloon. Of course, if you had used the stent balloon, it would have been a simpler thing. But I thought, there was also some calcium in the proximal left main. So I thought that proper post dilatation with a short balloon going up to high pressure, as Dr. Hemant Sir has told, I went into pressure of ultimate final kiss was at around 20 atmosphere pressure. Before that, I went at around 16 atmosphere pressure. So that was the thought of taking two balloons, this thing.
Dr. Navjit, I would like to add here that when you deploy the stents, you bring the balloons back, the stent balloon. The subsequent balloons may not always go in very easily. There's a wire bias and things like that. So even if you're taking N balloons, they may not go in easily through SKS technique. You are, of course, like V technique, and you probably won't have difficulty. But for SKS, this happens many times that the next balloons don't go in easily. So it's whenever I'm doing SKS deployment, I use the stent balloon to the fullest. Like, so I would deploy it at 8.8, then go slightly high. See, if you dissect distally, you will not be able to take a stent very easily through a deployed SKS stent. So you have to worry a lot about going high on pressure when you are doing SKS. If it is a single stent, I go with the stent balloon to 16, 14 very easily. But when I'm doing an SKS, I like to keep the pressures to maybe just around 8. So absolutely no risk of taking a distal dissection, distal to the stent. And then I would probably follow the steps that you did, that take a short balloon and go high on pressure and do a complete job. I think V-stenting was probably not used in the way you used it by many others, and that's why V-stenting got a lot of flake. While I feel it's a very simple technique. So whenever patient is very sick, I just like to go for SKS or V. I remember I was in Srinagar for some kind of cath lab demonstration. And as we were conducting a class in the side hall, the operator engaged an EBU and injected, and he dissected from left main to LAD and left main to circumflex. Patient crashed. So nothing was there except the catheter was a guide catheter and not a diagnostic catheter. And at that stage, we put 2 wires, just did a SKS, and patient stabilized. I mean, nothing else could have saved that patient if we had not done a SKS. So I think all these have their definite role. Like in your case, patient was a very hot case. You wanted to keep the contrast load down. So all these were helped by the technique that you chose. And I think every case sort of teaches you and I what should be the best therapy, what should be the best modality, considering all the associated risk factors in a given case. Like your patient was COVID positive, had renal issues, and so on.
Jabir, I think what you are mentioning was not because of the positioning alone, Navjit. While taking the stent balloons inside also, you could distort the stent struts. That's why people said nowadays with better quality of balloons, probably you're able to go it. Previously, the balloons were more bulkier, and when you're trying to pass it for post-dilatation, it would use to distort the stent edges. That was a worry, not exact precise positioning. But now what point you mentioned is stent viz helps in precise positioning, not to get the balloons out. But what Jabir was told before was, while taking the balloons itself, sometimes you could damage the stent edges.
Yes,
but
yes.
if you take care and do it well, what you did is perfect, because you can't afford to leave unexpanded stent also at that point. I think you did a good job perfectly.
Actually,
and COVID positive patient doing this, I really appreciate.
There are some juniors and my fellows, they, whenever we want to save on expenses on a given case, we like to take the O balloons. And O balloons are very difficult for this kind of restenting. So I think this has to be done with, and when you're entering the stent, you should not have any resistance. If you have any resistance, I think the tension on the back end of the wire should be changed so that the balloon would probably enter more easily into the stent. So it should not be handled like we handle a single stent.
Sir, in this case, we took all the equipment, including sheets, everything, and
COVID positive, no.
Because corona positive, I told them that don't do this thing, because many a times the technicians on their own, you ask a balloon, they will give you a O balloon, because they are under what I don't know. Many a times they do that. So I told categorically that everything, whatever we ask, give it N. We will adjust in any other case. Kind of. Many a times we have to do that.
Technicians are used to give us O balloons.
Yes.
Shabir, before you talk one more wrong line, all these are off records, okay?
Yeah.
So.
No, but the other thing what they said is colleague was telling was sending for patient for surgery. That's also no joke, doing surgery in a COVID positive patient. You did say you saved the life of patient, and I don't think surgeon would have done case if COVID positive.
Yeah. They would have waited for 14 days. This patient would not have waited for 14 days.
Yes.
And very high mortality in CABG in COVID positive.
Yeah. I think great cases. Okay.
So, Dr. Omkar, we are coming to an end. No more cases, right?
No more cases, sir. Only 3 cases.
Yeah,
that's more than a stent already.
I know. So, Dr. Omkar, you always take a tremendous effort, and I think last time also we had a very exciting cases. So we are really thankful for holding almost 1,000 intervention cardiologists together on this important platform. Congratulations.
Thank you, sir.
Sir, one request, if you allow me to announce, I'll take this opportunity to tell everybody. Anyway, they're getting communications also. The TCT India meeting we are holding on July, this month ending 29, 30, 31st. And many of Emcure is helping us in organizing and things like that. And some of the cases are also selected. And I requested, sir, you just received the mail, I think we sent you.
Yes.
Requested you for a live case, and sir will be doing a live case on 30th July. 4 to 5, and then probably we request you also to speak on EBC main trial later part of that day, sir. Thank you for accepting. And Jabir, you will also receive the communication. And thanks, Emcure is also helping us a lot. As you said, we discussed last time, sir. They are helping in organization of the TCT also. I request all the people who logged in also to utilize this opportunity and join for the TCT meeting on July 29, 30, and 31st. It will be from 3 to 9 p.m. Very interesting live cases and some international live transmissions also there. And wish everybody joins for that meeting. Thank you. Over to you, Omkar.
So thank you very much, sir, for this announcement. Thank you, our course director, Dr. M.S.C. Remat, sir. Thank you, our moderator, Dr. Jabir, sir, and Dr. Srinivas Kumar, sir. I also thank our 3 speakers today presenting 3 interesting cases. So we will be meeting for the next program on 28th of this month. As sir has mentioned, 29, 30, 31st would be TCT. So we have preponed our program for a day. So we'll be catching up on 28th. That's on Wednesday at 8 p.m. So with this note, let's stop here and let's meet for after 15 days for this program. Thank you. Thank you very much.
Thank you. Good night.
Recording stopped.
Thank you.